Okay. So we'll be streaming in Dr. Richard Gilroy from Boise for his presentation.
Okay. Hi, everyone. I am the medical director of Glorified Plumbing, which is mainly liver transplant, and I also do hepatology as well. I'm a gastroenterologist by trade, and as you can tell by my southern accent, I'm not from these parts originally. I'm also, I suspect, the medical director of airport experience, because I tend to spend most of my time on a plane going to outreach clinics either in Idaho or in Nevada. But I think some of you would also remember me for the fact that I do clinics actually at the Ogden Hospital, although we've expanded a little bit. I'm going to give an update on hepatology, but I'm not going to be talking about hepatitis C much because it's curable. The reminder statement to everyone is that everyone over the age of 18 by the new CDC guidance document gets a one-time test, and if you're a person who experiments with drug use, in particular IV drug use, or if you're an at-risk person, men who have sex with men, or work in industries where you might have high-risk exposures, that testing would be annual. So disclosures, I work on advisory boards for a couple of companies. That's actually probably out of date because most of those I'm not working with, but I do a significant amount of research in fatty liver disease, primary sclerosing cholangitis, and autoimmune liver disease, and we run multiple industry trials. And accordingly, therefore, I have a conflict of interest to make people aware. The other one is arguably standing here, I have a conflict of interest because if you find me in any way remotely interesting, or you think I have a gram of intelligence, which would be debatable, but you might also consider referring people to our program out in the mountain for hepatology and transplant services. The objectives I have today, I'm going to go over, I'm going to take you back a little bit of a journey back into medical school and look at certain aspects of liver testing. I'm going to talk about some aspects of liver disease management. I'm going to focus upon the roles of certain tests in liver disease management, including liver biopsy, and I'm going to give accurate stories of what actually has happened to people, but it's more a guidance on what to do about liver disease. But what won't be covered is, I'm not going to go in great detail into the changing profile of end-stage liver disease. I will make some mention to it, but I won't go through all of it. I won't do an update on, that's related to other uncommon tests for liver disease, but I will focus upon the testing that's appropriate for liver disease. I will deal with, the NASH population, and I'll talk about that, and I'm going to make reference to a tsunami. So, where does Utah and Idaho, you're in the northern part of Utah, you service some of southern Idaho. Where do we currently stand with liver disease and its management? So, just for everyone to be aware, 0.3% of the population has cirrhosis. This corresponds in Utah. When we have a look at the adult population in the US, that's about 650,000, probably 700,000 people in the US have cirrhosis, and about 8,500 people in Utah have cirrhosis, and about 4,600 in Idaho. Now, independent predictors of whether you develop cirrhosis are whether you're non-Hispanic, Black, and Mexican Americans, those who live in poverty, those who have a lower than 12th grade education, diabetics, obesity, alcohol use, Hep B, Hep C, men have more cirrhosis than women, and then as you get older. And once you get diagnosed with cirrhosis, and this is historic data, but it's certainly not as bad as this because we diagnose people earlier, but about 25% of people after a diagnosis are dead in 2 years. So it does become important, but it also reminds us of the importance of getting upstream of this problem, because if we can prevent people from getting to being identified with cirrhosis, then we prevent people from dying of that disease. So when we look at, sorry about that, CDC data, and I bring you, this is the crude death rate for liver disease across the country. And what you'll notice is that when you go to the right-hand side, you'll see places like Oklahoma, San Diego, South Dakota, Wyoming, and West Virginia. And they have a much higher death rate. And then you'll have a look at Utah, which is in the far lower left corner, and they have a much lower death rate from liver disease. Now, you see this huge difference, but if you actually look about 3/4 of the way to the right, you'll see Idaho, and they have twice the mortality from liver disease when a diagnosis of liver disease is made than people in Utah, because Utah's healthcare delivery system is optimal, and Idaho's healthcare delivery system, although improving in the rural community where there's a larger percentage of patients, still remains less than optimal. Your distance from a center of excellence in liver disease predicts the probability for mortality, and that's why when you look at New York, it's got the lowest mortality, but they always cry that they don't have enough organs for liver transplant. But again, this is the population that we are concerned about, and Idaho is the population that is near you that has significant issues that need to be addressed. So when we have a look at healthcare delivery by state, again, this is an important point, is that when you look over here for healthcare delivery, Utah is one of the best performing states for healthcare delivery out of all the states in the US. And then when we have a look over at this healthcare delivery system again, now this specifically, and this is data from the Commonwealth Fund, but there's many other data sources that allow you to look at this. But the bottom line is, when we have a look at our delivery system, Utah has not necessarily had a great degree of improvement recently, but the most important thing, that's coming from a baseline where their degree of performance is high. So all of the people in the audience, remember, you are the people who create this system. It's not individuals like myself. And what you've delivered is a state that actually has a much higher degree of clinical care. So then we have this, COVID-19, and COVID-19 does many things, and this is an article from the American Journal of Gastroenterology pointing out that it can cause an acute hepatitis. It also can cause a picture that looks like primary sclerosing cholangitis, and it also has been responsible for 700,000 additional deaths. When you hear patients discuss things about COVID-19 and mortality and saying that, they're not sure and they don't think there's a big change, it's always nice to go to the crude data, and we know that 2.85 million people died in 2019, and then we know in 2020, 3.35 million people surrendered their Medicare numbers and died in that year. So that the actual death rate is considerable for this, and from my perspective, in liver disease, is becoming particularly problematic because I'm seeing people with lung disease who've got COVID-19 associated liver disease, and a lot of it looks like primary sclerosing cholangitis. So when we look at our program, the transplant program, just for people to be aware, these are data that compare you to averages. When we look at, this is data for published in 2019, but we have additional data now where we're still sitting at about 93%, 93.5%. That means that if I do 100 transplant, only 7 people die after transplant. That's compared to waitlist mortality, where 2 out of every 5 people nationally who get listed will fail to receive a transplant. So we overcome that different ways. We do living donor liver transplants. Donors, we prefer it to be younger, but anyone can be a liver donor in a deceased capacity. The oldest organs we've transplanted are in their 80s. And those organs work just as well when well selected in terms of patients, and that's why we see outcomes and the probability of patient survival here being 95%. Now, what we have is we have a comparatively low waitlist mortality because we're quite aggressive in identifying organs. And for us, it's always a decision, is it good enough and the decisions always made, is it good enough for us if we were like them? And so we want to have this waitlist mortality low, because remember, if you can impact that, you have the greatest impact on the probability of mortality, because 2 out of every 5 people nationally die without a choice. And David Goldberg and I published some data in the Journal of Hepatology, and David extended to a New England Journal paper, where we looked and identified that it was actually the program's clinical decisions around organs that had the greatest impact on whether someone lived or died. It wasn't the availability of organs in the community. And again, if we look at comparative data to another Utah program, you'll see that their waitlist mortality is higher. And that's because we make different decisions around the same organ. And that all comes down to a subject I'll talk about later called prospect theory. So when we compare the two programs, this is us versus the University of Utah. This is 2020 data going through to 2021. You'll see that in 2016, in terms of the total people we listed 51 patients for a liver transplant. And last year we listed 127. That would indicate a degree of growth. And interestingly, if you have a look at 2019, we went from 73 to 127 during COVID, because we modified our operations quite quickly. Our transplant numbers went from 37 to 79, which would be expected. If we look at other programs, the listing rate didn't statistically change, and in terms of the transplant rate, it didn't statistically change. And that indicates that their operations were able to remain stable, which is good. Some programs in the US had a halving in volume. My previous program went from 97 down to 45. So when we have a look at this is something I want everyone to remember, is that everything that we do in transplant is a story of damaged goods or repurposed goods. Damaged goods meaning that someone's died of a stroke, a heart attack, they've got cardiovascular disease, but we use that organ in a recipient. And then the other one is repurposed goods, is we take a portion of someone's liver, up to 60% of their liver, and we give that to someone else to see them successfully transplanted. And when we have a look at the actual numbers of people, this is where the biggest challenge is, and this is looking at the changing profile to liver disease. In 2011, we list about 50,000 people, and 7,000 are over the age of 65. This isn't listing, sorry, this is people who come along to be donors. But what we've got is, we see a substantial increase in the total number of people that we're looking at, and a substantial increase in the total number of people nationally over the age of 65 being indicated for a transplant. So we have a supply-demand mismatch, because we're transplanting people over the age of 65. And as I rapidly approach the age of 65, and every gray hair that I accumulate every day reminds me of this, I realize that I hope never to be in that group of individuals, that 11,000 people listed nationally for an organ transplant. But many people are being considered for organ transplants, because we always find ways to transplant them. What we're not doing very good at is finding ways to identify organs for them. And again, this is sort of another projection. This projection you see at the top here is a projection of liver disease. And this is the diagnosis of cirrhosis, the US population data. So we see how much the US population has actually increased. And when we compare that to the total number of people at the bottom of the screen who are over the age of 65 being listed for a transplant, so this is for any organ transplant. We've got 7,600 people listed in 2011. In 2018, we've got 11,900 people listed for a transplant, which is a substantial percentage increase. But the US population in that time frame only goes from 306 million to 327 million, meaning that we find more people to transplant, but we don't find necessarily more organs. So again, this is the hepatitis C curves, and we came up with things called direct-acting antivirals. I believe Select Health, or I would hope that Select Health has moved in the direction to allow anyone to treat. It's a once-a-day treatment. It is as short as 8 weeks, and in transplant it can be as short as 4 weeks, because we treat people who received hep C positive organs with treatment the day after, and we can treat them if they have a hep C kidney for 4 weeks and get a sustained viral response or a cure essentially of 100%. Most cure rates for either drugs that are available are between 97 and 100%. So hep C was a problem, but it's not. Instead, we replaced it with something new. Everyone, when you look around the people next to you in the room, and when I look at myself, I realize that if I was living in the 60s, I would be a heavy person. And that's because the average BMI of people has increased considerably over time, and I'm one of those people who's got a BMI of 30, and I should have a BMI of around 22. But people would look at me, I like to wear suits to hide my weight. I think it works. But the main thing is that people look at me and don't think I'm overweight because the population around me has gotten so much bigger. But if you look at the number of transplants for fatty liver disease, we see this increase that's gone from being sort of around 200 to 300, and now we see the numbers that are more accurately approaching 1,000 and actually in excess of that, because a lot of these, and that arrow is supposed to put HCC, a lot of the NASH patients develop hepatocellular carcinoma. So that's the big issue, and the annual incidence of HCC in anyone with cirrhosis is 3% per year, and the guideline is anyone who has cirrhosis gets an ultrasound and an alpha-fetoprotein every 6 months, and that's the AASLD published guideline. Again, this is basically just pointing to the other one that's gone up with COVID terribly. Every hospitalist in the audience will remember the fact that they're seeing more people with alcohol-associated liver disease than ever before, as will every primary care physician who will be managing these people in the community. So this is the obesity trend map, and probably most telling is the fact that we had to get a new color scheme, because in the 1990s, where it was a beautiful blue, and for all those people who support North Carolina, they'd be happy. But then we decided we'd change it to more a Utah sort of color. And so in 2010, we've actually revised it. But if you look at those percentage of people who have obesity, and you see that red area, which is also problematic for us on many fronts, because it's also the same areas where you have the lowest quality of healthcare. So the number of people dying with these diseases is rapidly transforming. And again, we had to come up with new color schemes again, because guess what? We had more obesity and greater rates of people with BMIs greater than 30, and it